and everyone's right on time. So isn't that fabulous? Welcome
Perfect.
back, everyone, to Grand Rounds. This is our first Grand Rounds of the new academic year. I hope everyone has had a fabulous summer and a great Labor Day long weekend. And that back to school has been really a special time for everyone. So I'm delighted to welcome back one of our CHEO alumni, but before I do his introduction, I'm going to start with our land acknowledgement to remind us that Ottawa is built on unceded Algonquin and Anishinaabe territory. The peoples of the Algonquin and Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. And as promised, this is an introduction for Dr. Evan Cole Lewis. I didn't know that was your middle name, Evan. Evan is a alumni of CHEO and University of Ottawa. He is a neurologist with focused training in pediatric neurology and epilepsy, and holds an appointment as an assistant professor in the Department of Pediatrics at the University of Toronto. He is the founder and medical director of Numinus Toronto, which is formerly the Neurology Centre of Toronto, and chief medical advisor for the JMCC Group and VP Psychedelic Neurology at Numinus, which is a Canadian company focused on research and therapeutics with psychedelic medicine. Dr. Lewis's broad clinical and research skills encompass both psychedelic medicines and cannabinoid therapeutics. He utilizes ketamine-assisted therapy and medical cannabis as interventions for diverse neurologic disorders, especially concentrating on epilepsy and functional seizures. He actively engages with many global research initiatives and patient advocacy groups within these domains, and his extensive expertise is frequently sought out for national and international lectures. Evan is a co-investigator for 2 medical cannabis trials, one targeting chronic headaches among adolescents and the other using cannabis to address drug-resistant epilepsy in both children and adults. So I think you would agree that he is coming to us with a wealth of knowledge and experience in this area. Today, the title of this presentation is Introduction to Psychedelic Medicines and Potential Applications in Adolescence. With that, I'm going to hand it over to you, Evan.
All right. Thank you so much, Mona. It's a real pleasure to be back here and to see everybody. I'm just going to pull Zoom up. There it is. Okay. Yeah, and it's really nice to see everybody. So great to be here and excited to do this. There's so much material with this, so there's lots to present for everybody. Hopefully we can get through it. I might speed through some of it just in order to get through the Q&A. So if I do and it goes over your head, don't worry. I've been reading about this stuff for 10 years and I still feel like a rookie at times. So it's pretty overwhelming, but so fascinating, so interesting, and just not only their applications potentially for adolescents, there's applications that spread such a breadth of what we all see. So my hope today in doing this really is to kind of introduce everybody. I'm going to show some very particular elements of where psychedelics can be utilized, but I hope I'm trying to ground this in a bit of some more basic principles to have everybody else kind of open their mind a little bit to see and try to explore where this might work in their area, just because there is such a transdiagnostic application for psychedelics, and that is really rooted in the neurobiologic mechanisms upon which psychedelics work. So it's to whet everybody's appetite, get you interested, and love talking about it. So hopefully we get time. I'm going to try to get time for some Q&As. All right. So without further ado, I'll kind of whip through the first bit. Here's a bunch of disclosures. It's all there. Mona kind of mentioned many of them. And here's some more of disclosures in terms of kind of speaking representations I've done. So today, really, although I do hold a position at Numinus, there's really no mention of them today. It has nothing to do with what I'm talking about. And if people have questions about that after, very happy to talk to you about this. This is really just a knowledge-based presentation for everybody to get acquainted with psychedelics. So flipping through this, here's the outline for today. So we're going to look at an overview of psychedelics. I'm going to touch on just ketamine and psilocybin mechanisms, very kind of high level, look at mental health and psychedelics, then look at the applications in neurology, and then specifically at the end, very, very briefly talk about functional seizures and their treatment with ketamine.
Evan, just to let you know, we're seeing your Zoom screen, not your slides.
Oh, that's not great. All right. How
Perfect. Oh, yeah.
are you seeing the slides or
We're seeing the actual slides. Yeah, the right slides. Yeah.
okay? So I'm going to be kind of looking here. Sorry, you might do that side view my face. It's just my setup. Normally it's the other way around, but okay. Thank you for saying that. No one really missed anything. It was just a bunch of busy slides with a bunch of text. Anyhow, all right. So here's the outline. So as I mentioned, and then just at the end, we're going to touch on functional seizures in their treatment with ketamine. Okay, so quick test. So we can do this. I mean, I'm happy to look at the chat. If everybody just wants to kind of pop in answers up there. Here's a little quick test. Let me see if I can get the chat. Oh, can't find my chat. I feel like I went to a new setup. All right, well, that's okay. We'll just kind of go through this. Put in the chat if you see anything. I'll try to see if I can get this chat pulled up here. Okay. Oh, so first one here, the name of this organism, I just gave it away. Given I can't see the chat, I'll kind of just let everybody kind of go through this and I'll do it more out of interest. So the name of the organism here, this is a mushroom, okay? So the name of this organism is Psilocybe cubensis. So Psilocybe cubensis is this particular type of genus of mushroom. And the associated psychedelic compound, may or may not know, but that's where psilocybin comes from. So it doesn't specifically come from this species of mushroom, Psilocybe cubensis. There's many mushrooms that have psilocybin in it. This is just one of kind of the most popular one that we know of. Next is this little plant here. So if anybody is familiar with that, it's a type of cactus, and this is the peyote cactus. Okay, so Lophophora williamsii is the other word for it. What is its associated psychedelic compound that we find in this? Well, the famous mescaline, and that was made famous by a couple characters we're going to chat about in a few slides. The last one here, there's another type of psychedelic brew that comes from two plants, actually, and these plants are typically found in the Amazon basin and throughout South America. Particularly Peru is kind of famous and known for this. This is what ayahuasca is, and that's how you spell it, because I've seen so many different spellings for it as well. It's really fascinating psychedelic compound because it's made of actually two main ingredients. The first one is chacruna or Psychotria viridis, and that's this plant right here. And this is the real active psychedelic compound. This is dimethyltryptamine or DMT. It comes from that particular plant. But the problem with DMT is if you consume it orally, it breaks down in the gut and none of it really gets to the brain. So you've got to mix it with Banisteriopsis caapi. Banisteriopsis caapi is the vine plant you're seeing here, and it has a monoamine oxidase inhibitor in it. So when you mix the two of these, it prevents the breakdown of DMT in the gut. Most DMT goes to your brain, and that's the active molecule. So you got to combine these two. And when you do that, you get the effect of ayahuasca. So those are the two major compounds in ayahuasca. Okay. Next up, here is a really interesting little fact. Again, I can't see the chat. Normally I do this and we'll see kind of answers, but between 1950 and 1965, how many papers does everybody think were published on the psychological and medical effects of LSD, otherwise known as acid? I'll give you a little bit of time to just think of those numbers, pick one in your head, and and you're going to be surprised, probably as most people are, because over 1,000 papers were published at that time. And it really was this real buried history of scientific breakthroughs and medical breakthroughs with using psychedelics, where after Albert Hoffman, this individual here, discovered LSD in 1943, it went through this massive period of research, mainly in alcoholism, and a lot of that was being done actually in Saskatchewan, believe it or not. It was a major center for the treatment of alcoholism with LSD. Pioneered a lot of research there. Oops. Okay. So going to take you very, very briefly through this. This is not meant to kind of read through everything. It's just really to show you the degree to which psychedelics have been present in human sociocultural history for so long, and our medical history as well. So we go back to prehistory, and you've got real representations of psychedelic use in humans. This is a fascinating thing, the Eleusinian mysteries. So there's a potion called the Koukion that was drank by ancient Greeks, which was has now been pretty much proven to be a psychedelic brew. There's a great book about this called The Immortality Key. If you're interested, I'll let you know. But this definitely lets us know that this has been, psychedelics have been used in kind of practices in very advanced civilizations like the Greeks. Even Aristotle describes going to Eleusis to partake in the Eleusinian mysteries. Early modern era, you get into kind of the period between 1500, 1900, and you've got documentation of psychedelic mushroom use. You've got documentation by the Spanish conquistadors talking about the Aztecs using mushrooms. Fast track now into the golden age of psychedelic research. This was, as mentioned before. So LSD is synthesized in 1943, and there's tons of research that's done in this period of time. Mushrooms are kind of rediscovered by Western culture, and that gets integrated into research as well, and starting to use this for kind of the treatments that took place at that time. Now you get into the turmoil, a little bit of kind of the counterculture wars and everything that arose in the 60s. And this is a major cultural shift. So much so that Richard Nixon in 1970 declares, the war on drugs, and makes kind of pretty much, all these psychedelic substances plus, schedules them as Schedule 1, meaning that there's no medical application, despite the fact that decades before that, the 2 decades before that, there was this explosion of research. So that pushed psychedelic use underground. But the point was, there was a real group that really continued to utilize the practices discovered in the 40s and 50s, and the practices way before that for thousands of years that have been in use. And that's when this gentleman here, Rick Doblin, founded MAPS, which is the biggest nonprofit association that's really put psychedelic research forward, which is so fascinating about this guy. And I'll just take a little sidebar here to tell you about it. 1986, he knew the only way to get psychedelics back into the medical field was to take one of the drugs and put it through the FDA, the whole drug process. So that was his PhD in 1986, literally how to get MDMA through to the FDA. It's now 2023. Next year, MDMA will very likely be approved by the FDA for the treatment of PTSD. That just shows you, if you really want to, pick a goal in life and stick to it with enough perseverance, you can make it happen. And he has, real admirable to think about what he's done. So that kind of heralded in the 1990s. You've got, some interested scientists rediscovering these molecules more or less. And then Dr. Roland Griffiths, publishes this big landmark paper in 2006 about psilocybin and how it imbues mystical experiences, and then kind of this renaissance of psychedelic research and clinical work begins. And that's this period really in the past kind of couple of decades, tons of advancements neuroscientifically, medically in the field, real amazing stuff, and really figuring out the neurobiology of psychedelics and the neuroscience of psychedelics, which is what is most interesting for me at this point around all this stuff. And then you start to see the social change. This is what we're all now experiencing, right? Really galvanized, I think, by COVID and everybody hunkering down and learning about this stuff. And but especially in Canada, Canada really is one of the countries that is leading the charge a little bit in terms of access. So much so that right now, a physician can apply to the government through this special access program to get MDMA and psilocybin for people, for certain indications for individuals. And at this point, that kind of started in early 2022. And there's been quite a few applications approved up until this point. I've got a couple actually myself, and that have just been put through, and we're waiting to hear a decision on them. So really a lot coming. That was kind of a very fast whirlwind of psychedelic history. Let's talk about what they are, okay? So the way to look at psychedelic drugs in general as kind of the whole group of them, they alter conscious experience, okay? And it really is in bringing on these kind of non-ordinary states of consciousness, which is just an alteration of perception, mood, and cognition. What does the word psychedelic mean? It's derived from a couple words, both psycho and dalom, which means mind manifesting, which is a real appropriate word for it, and actually really interesting conversation between these two individuals. This is Humphrey Osmond. So he was one of the gentlemen who was working at Saskatchewan, doing all the work on LSD and alcoholism. And this character down here, Aldous Huxley, you may know of, wrote The Doors of Perception, and he wrote The Doors of Perception based on his mescaline experience. Remember, mescaline comes from peyote. It's one of those psychedelics. And in the exchange of letters, because back in the day, I guess that's what we did. We wrote letters to each other, and you have time to write poetry. So they were coming up with, what do you call this thing? These drugs that bring you into this state. And it was actually Humphrey Osmond who wrote this. And he said, to fathom hell or soar angelic, just take a pinch of psychedelic. And thus was born the word psychedelic. Real important thing here. I'm going to play this video here while I'm talking. Okay. It's really important to understand the difference between a hallucination and an illusion. Right. So on the left, that's representing a hallucination. A hallucination is kind of a manifestation of perception that you create out into reality, where an illusion is reality coming at you and creating a change. And it's really important to understand the differences between those, because this is one of the most fascinating illusions I've ever seen. That thing is flat as anything. And as you walk towards it, it's even hard to look at. It's totally 3D and sticking out at you. So that's something in the external world which is giving you an altered perception of actually what it is. So that's what an illusion is. So psychedelics kind of do both. So a lot of people think when you are looking out into the world, you're seeing trees shimmering and faces on things and everything, that is, everybody calls those hallucinations. Those are illusions that psychedelics is creating. And it's a really important part outside the scope of this talk when we dig into kind of the modernized concepts of neuroscience and how the brain operates using concepts like predictive processing and things to really understand the difference here. And it really does help you understand what the experiences of psychedelics are doing and what they're producing. So an important concept, we'll kind of touch on it a little bit to see, but important certainly to differentiate. Okay, looking at psychedelics as a group, how do you classify these things? Well, one way to look at them, they're bucketed as a hallucinogens, even though I just went and told you it's not a great name for it. This is an older term, but they're still classified that way. So I'm going to use it for here. That's hence why I put it in quotes. It's definitely a misnomer and needs to change. Will in time for sure. But let's look at them. So there's the classical psychedelics. What are the classical psychedelics? They're grouped as classical because they have the same mechanism of action. They are serotonin 2A receptor agonists. Very well defined. All right. And what is that? That's psilocybin coming from mushrooms, LSD as well, which is synthesized but is rooted in a mushroom as well. It's rooted in the ergot fungus. Mescaline and DMT, and DMT I told you was from the Chacruna viridis, that component of ayahuasca. All right, so those are your classical psychedelics. Now, when you get to your atypical psychedelics, or maybe the non-classical ones, what do you have? You have your empathogens, the psychedelics that evoke empathy, right? And they're monoamine reuptake inhibitors, and that's like MDMA. So that's where that sits. You have your dissociative agents, okay? They are specifically NMDA receptor antagonists, okay? And that is like ketamine. And then you have your various mechanisms, and this is like cannabis. So THC actually does have some mild psychedelic properties, right? If you think about what the definition of psychedelic was and viewing states of non-ordinary consciousness and altering mood, perception, cognition, sounds a lot like what THC can do. Some others as well, ibogaine and salvinorin A. Okay, so that's kind of to group these things so you have a sense of where these things are and how they fit. The real next important part is really understanding the treatment model for psychedelics, to put this into context, because there's a lot of misconception. We come in with our kind of classical, traditional, very westernized style of medicine, take this drug and go home and I'll see you in a little bit. The psychedelic model is quite different and important to understand, right? Where it's used right now and being used quite well is as an assisted component to therapy. So what it's really doing is you're utilizing the psychedelic to catalyze a process. And that process is in combination, or at least potentially optimized in some cases, with psychotherapy, such that it derives what we call context-specific insight. So we've all had context-specific insight. You've been mulling around an idea for a while, and then you're walking around one day, you're just taking a stroll or taking a shower, and all of a sudden, boom, like it comes up and you have the thought, you have the light bulb. And then it's kind of like, you know, how did that happen? Well, that happened as a component of everything that happened before that. It wasn't just that thing in isolation. So this is what psychedelics do. Psychedelics really help to kind of, you know, by catalyzing the psychotherapeutic process, it really helps a psychotherapist and yourself get into the root of what's underlying the problems or the issues that you are just experiencing. And it brings forth that insight. And this has to be done in a really specific protocol and framework right now, which both optimizes what can happen, but also ensures safety as well, because imagine, right? If you are somebody who has deep trauma or significant, past experiences that are quite distressing, and you take a medicine and then talk about it, and suddenly it pops up, it can be very overwhelming. So it's really important that this is attached to a real strong psychotherapeutic model. Now, the other piece is there's minimal drug exposures. So it's only 1 to 3 treatment sessions. This is not something that you do every single day. Microdosing, you might think about it in your head. That's a totally different ballgame. Happy to answer questions about it, but it's not what I'm referring to here. So what exactly are we treating with psychedelics? Okay, I like to, on the right here, that is a list of kind of evidence-based trials, observational trials, real high-level phase 3 trials, for instance, with PTSD, a lot of late-stage phase 2 trials, et cetera. Here's a bunch of the different conditions that have been utilized. So that's what makes, I know you can get very skeptical. I was skeptical too. I've been skeptical in neurology when things have arisen like this, where it's like, how does one thing treat all these things? How does it have such a transdiagnostic treatment? Well, first off, the evidence is showing it. Second off, if you look at this in a different fashion and be like, well, what do these all have in common? Well, this is how I look at it. They're all disorders of brain networking. And that's this litany of diagnoses I'm showing you here. And given that the fundamental basis of every single one of these is nested in the brain networks being disrupted, if you have a brain network medicine, might it then work for these? So then that begs the question, have we just classified all these things incorrectly? Or do they exist under a bigger umbrella with subtypes? And this is where psychedelics is so fascinating, because it's making us ask these questions, and it's really pushing forward the field of psychology, psychiatry, and in my opinion, neurology. And this is, again, takes a little bit more discussion. This is what I'm going to discuss a little bit more in the ED rounds after this, but a real cool way to conceptualize this and understand why this might be working in so many different indications. So what's available in Canada right now? Well, as I mentioned, psilocybin and MDMA are available by the Special Access Program, also in clinical trials. Okay, ketamine though is available off-label. It's an anesthetic, so it's available there to be prescribed. So many different uses for ketamine, or many different people are using ketamine for many different uses off-label, and that's freely available as well. So let's talk about ketamine just real quickly. I know that there's probably been some discussion about ketamine at CHEO, at least in the emergency department. But let's talk about that one here, because again, it is available right now. I'm using it clinically, and other people that you might know are probably using it as well in terms of treating patients with it. So here's a little bit of background, very high level, synthesized in 1962. This is often unknown, but ketamine was discovered as a treatment for depression in 2000. And I have a follow-up slide to this. I'll hold to talk about the origin of that. But now has many off-label uses, formulations, that you have oral nasal injections as well. And recreational, obviously it's illegal, but approved as an anesthetic, but also approved in the US for treatment of depression since 2019. And that's a nasal form, a spray nasal form called Spravato, which is only one of the enantiomers of ketamine, hence S-ketamine. It's the L form of ketamine. So that's approved in the States. Lots of implications to talk about this and everything, but I'm going to talk about it in terms of its mechanism, and I'll briefly talk about it in the clinical context in which I use it as well. And that's again, the assisted therapy model I brought up before. So what's the molecular mechanism of ketamine? Again, very high level. This is a super busy slide. I'm just showing it there to basically illustrate that there are multiple mechanisms of ketamine. We actually aren't entirely sure what is doing what in terms of the patient's outcomes. We're really teasing it apart, and there's actually unbelievable, amazing research here. If somebody's interested, of any neuropharmacologist, we'll have a field day with ketamine. There's so much to explore here. But really, this is what I want to focus on. So I want to focus on up here because this is what's important to understand. This is the primary mechanism. The primary mechanism is an NMDA receptor antagonist. Okay, and so I'm going to walk you through this pathway here just to give you very high level. Okay, here's what's really interesting. When we use ketamine as psychedelic, we do not give the anesthetic doses. If you give anesthetic doses of ketamine, you're falling asleep, you're unconscious. It's a totally different thing. When you give these sub-anesthetic doses that allows you to retain consciousness yet experience the effects of ketamine, it's acting a little bit different. So at lower dose ketamine, what we find is ketamine will preferentially block NMDA receptors on GABAergic neurons. So these are the inhibitory neurons. It blocks inhibitory neurons. If you're blocking inhibitory neurons, you're preventing GABA from being released onto excitatory neurons. Therefore, downstream, you have a large amount of glutamate release. Right? So it's an upstream blockade of an inhibitory neuron, blocking inhibition on an excitatory neuron, therefore activating an excitatory neuron. And when it does this, it activates the AMPA receptor. And the AMPA receptor is tied into brain-derived neurotrophic factor, which, if you follow all this down here, creates proteins. What proteins does it create? It creates spine formation. And then spine formation creates more connections. More connections mean plasticity, right? Changes in the brain. So that is kind of it's one mechanism of ketamine. I'm doing it a disservice by just saying that just this alone. But that is the primary mechanism I kind of want everybody to just take into. So what the psychedelics are doing is they are creating the opportunity for long-term change. Okay, by generating plastic response. Okay, great. Now, when we look at the very acute expression of this, though, what it's doing is it's exciting all these excitatory neurons. So what you see with ketamine really interesting is that within 24 hours, it has very rapid effect, okay? And that rapid effect occurs in increasing the density and the function of synapses. So it makes them actually build out structure, but it also it causes them to be more efficient. So they're actually exchanging information faster. When you do that, what happens is it creates a more globally connected brain network. So look at this here. This is a real cool study. And it's showing at baseline here. This is, if you look on the right here, okay, higher colors of this orange red color means more activation of synapses, okay? So you look here, and this is someone at baseline, and their synaptic density is not great. You've got these little patchy areas of red and orange, right? It's the baseline. 24 hours after ketamine, look how lit up this brain is. So what it's telling you is the neurons are interacting with a lot more. So to put this into context, somebody who's very depressed, right? Very depressed individual has not a lot of activity amongst its networks. You can think of it as getting locked in. You get locked into a certain brain state, and that brain state, by being locked into it, doesn't communicate amongst itself very well. Then suddenly you open these floodgates, and suddenly the brain can communicate with itself. Maybe you can, and this is really the insight that can be derived. This is the wellness that just the well-being people feel within, within 24 hours of ketamine. So it really has to do, and we're still teasing this out, with a function of almost immediately increasing the global functional connectedness of the brain. Okay, and this is another study just showing that increased connections between the posterior cingulate cortex and the precuneus increases. So when you start looking at which networks are actually kind of increasing in their connectedness or in their communication, or even breaking down some of the networks as well, then you can start to understand how this translates into some of the specific symptoms, right? People might have in various conditions like depression or anxiety, etc. Okay. Okay, let's move to the classical psychedelics. So again, I'm just going to use psilocybin as an example here. And psilocybin has a very specific mechanism of action. And its mechanism of action, so we're talking about these guys over here, the 5-HT2A, the serotonin 2A receptor agonists. Okay. Well, first about psilocybin. As I told you before, psilocybin is produced by lots of species of fungi, so over 200 of them. Peaks at 40 to 60 minutes. It lasts about 2 to 6 hours. Was marked for breakthrough therapy for treatment-resistant depression in 2018 by the FDA. Currently legal, only available through special access or clinical trials in Canada right now. Okay, here's its mechanism of action. So it's a receptor, 5-HT2A receptor agonist, okay? So it goes in there and activates 5-HT2A, okay, on both. What does it do? Okay, well, in the deep cortical layers, activation of 5-HT2A can reach up into higher cortical layers. It can actually reach across cortical layers as well. So it starts to create more activation within cortical neurons, all right? And not only does it do that there, but ultimately what it does is very similar to ketamine. It does cause some glutamate release, which acts on the AMPA receptor. Remember what the AMPA receptor does, ultimately it creates BDNF. So there is a downstream effect for psilocybin to also induce plasticity or metaplasticity as well, which is really fascinating with it too. So where do we find these 5-HT2A receptors? Well, they have so this is a study here. It's showing the kind of relative density of where you find these receptors, and they're clearly found in some areas, very cortical, as you can see here, very cortical, right? But does have a predilection, right? As a predilection for kind of the parietal, the temporal-parietal junction, the temporal lobe, frontal lobe, right? Medial frontal lobe. But you see, it's not really in kind of the post-central, pre-central gyre. So the motor cortices are kind of, they're bland at these, where the others, where it exists here, right? Temporal lobes. Really interesting. Okay, so if you map out where the 5-HT2A receptors are, they map out to some very specific networks that have certain specific functions. Okay, so you may have heard, if you've kind of done any navigating into psychedelics, you may have heard of the default mode network, or interest in neuroscience and brain networks, you might have it there. But the default mode network is a very fascinating network. It is known kind of for self-referential processing. So when you close your eyes and you daydream about yourself being on a beach somewhere, or you kind of think back in time to, those times you had as a kid, or just maybe over the summer, right? When you start doing all that self-referential thinking and thought, dreaming, daydreaming, etc., that is your default mode network. So we know that by putting people in a scanner and having them do that and looking at resting state fMRIs and seeing which regions of the brain light up. Right? Salience network is also a really interesting network. The salience network, so its name salience means what's salient. So it is a network that draws your attention to things out in the environment or inside of you. Okay, so if you're kind of sitting during this talk right now and your stomach starts gurgling, and that is kind of you kind of instantaneously stop listening to me and switch to that. That's your salience network kind of telling you that that's an important thing, attend to that, right? Or we're kind of talking right now and I've got my window here, and let's say a bird flies by and it's flying close to the window. I might look up and catch that bird. That's my salience network telling me that thing's important, go attend to it. So it also attends to things about ourselves as well, right? And these seem to be very key areas where we find 5-HT2A receptors, and therefore find the areas where psilocybin and some of the classical psychedelics have action, right? So what exactly happening when you activate these 5-HT2A receptors? Well, again, you got to really get into the nitty gritty. I've kind of given you a very big overlay. Like if we activate them, we're going to have some changes in how we think about ourselves. We're going to have some changes in what's important, right? We might be, and we might be actually, by activating those receptors, we're not going to be thinking about things as being less important. You're actually going to be thinking about things being more important because you've activated the salience network, right? If our default mode network, what's very interesting here, what happens is it looks like activation of these receptors in the default mode network actually turns down the default mode network. So remember, default mode network is a lot of thinking about yourself. Activation of the receptors turn it down, so you think less about yourself. Hence, maybe why this works in depression, right? Depression is a disease of really self-rumination. If you can break that self-rumination, can you then draw yourself to things that are more important and maybe make some immediate changes? And so let's look at that, okay? When we look at what psilocybin is doing relative to placebo, this was a very famous experiment that was done using about 15 individuals and kind of amalgamating their fMRI changes. And these big bubbles and little bubbles here refer to brain regions. And kind of the bigger the bubble, the further away these regions are. So you can see in the placebo state, your brain is networked in a very specific way, right? And it's constrained to some degree. These were healthy, normal controls, right? You would presume someone with mental health issues or kind of some of the other brain network disorders, they would even have more constraint here. You'd be more stuck into certain patterns. Then with psilocybin, and this is literally within the scanner. This is, I think, I was looking here, I think it was within 12 minutes into the scan. And then they did it kind of 14 days later as well. And they did the same thing when they kind of switched the groups. You can see that psilocybin almost immediately causes a significant degree of global connectedness in the brain. Or another way of thinking about that is saying decreased segregation, meaning that these little brain areas that were kind of independent, right, are not functioning so independently anymore. They're kind of now communicating with each other, right? And if anybody has talked to a patient or knows that some of the psychedelic experiences can be like, you can have ideas come out of music. Well, that sounds like a crazy thing, but not really. I mean, if you've got your areas of self-reference kind of turning down and you're creating kind of more areas that allow you to kind of day wander and explore, and then you've got more openness to more importance of music, and these things are talking to each other, you might find some importance between some sounds that you're hearing and ascribe some very important thoughts to them that actually might be very meaningful to you. So it's really allowing kind of the brain to interact in all of its different regions more in a more connected fashion. And that's what we know it's what's called as synesthesia. Everyone knows, right? Synesthesia is the kind of the sensory experiences that combine with each other. So, the psychedelics, by virtue of what they do to brain networks, invoke these synesthetic experiences. So why would the 5-HT2A system? Okay, so it's there. So the psychedelics aren't doing anything that, they're not adding anything to the system. They're just acting on a system that's already there. So there is this system inside all of our brains that, if you activate it, kind of destabilizes the integrity of the brain. It breaks down the brain and kind of makes it all a little bit more connected. So, like, why would there be a system like that in our brains? We all have it because it's a very reliable thing that most people, you put them in the lab, you put them on psychedelics, everybody has a very similar experience. So we're all acting on the same type of system here. That means we all have it. It's conserved through culture or through genetics, etc. Well, it means it's probably pretty important. So what is it actually doing? Okay, so this is a framework to think about what it's doing. Humans kind of, evolved out of nature, and we were, it wasn't so easy to be outside all day long in the environment, and climate changes over time and everything. So, one way to think about this system is something that's been conserved through time, because when activated, it permits perception to change such that you are not fixated in the perceptions around your local environment, and you don't have true belief in them. You're not stuck with them. Let me give you an example. So you're a group of humans living on the plains in Africa, tens of thousands of years ago, and you've had a great life there, beautiful trees with fruit. You've lived a few generations, your tribe, and then all of a sudden there's a drought for like 3 or 4 years. Okay. Now that stress comes in. There's stress. There's all the physiologic stress that comes with drought, food starvation, your friends dying, your tribe, and then all this, but you know what you know, so you stay there and you feel safe. And then somebody, the system gets activated just for you to see patterns. And then one of the humans off in the distance sees a little bit of green on the horizon, and kind of says like, oh, well, green is related to fruit. And this idea pops up, and this whole concept pops up that could there possibly be fruit like the fruit we used to have in the far distance? And it just permits that kind of openness, which permits that openness to psychological change. And that's kind of like the cool idea of human adaptability to stress. So it's thought that the 5-HT2A system is really kind of a system that buffers stress, or is activated by stress, such that you are then open to exploring more possibilities, to understanding what the stress is, and therefore moving away from the stress. So a really, really cool thing. And this has actually been shown in a very recent study. This just came out. This is August 2023. I love this because it kind of reinforces this idea. This was two groups of people. Famous study. This is actually a cohort that was published in Nature, where they compared psilocybin to escitalopram. Basically, they gave 2 doses of psilocybin with therapy over 6 weeks versus escitalopram daily for 6 weeks. And it showed that there was total equivalence in the depression scores. So they've done a sub-analysis on this thing called experiential avoidance, which basically just refers to somebody who avoids negative experiences. And part of kind of perpetuating the cycle of mental health complexities and even any disease we have, or even ourselves and our own behavior, is avoiding those really hard moments, right? And what they showed in this group was that this experiential avoidance was reduced at 6 weeks as well, which was associated with improved mental health outcomes. So is it that, thinking back to this model, is it that activating this 5-HT2A system allows you to be more open to experiencing negative stimulus, taking a bit of risk and stuff like that, where normally it's a bit more conserved because we're a bit stuck in our ways, or our brain networks are stuck down in what continues to allow us to move forward. I mean, so that's something to consider, and a really cool, I think, way to reinforce this idea or concept of what stress can do. So really, in summary, from what are the general effects on the brain, okay? We talked about this decreased segregation. It expands things. So decreased segregation is very similar to like decreasing differentiation, right? Our brain is differentiated into certain networks on purpose, so we reduce that. And what this has been discussed in the literature, what it's doing is it's increasing entropy. It's increasing the disorder of the brain, right? Like a brain that's very segregated and locked into its very specific networks has much less entropy. It's a much more ordered system. So by activating the system, decreasing differentiation segregation, we're actually increasing the amount of disorder, which could be favorable for a short period of time. Really, this is what you're doing. So by increasing disorder, you're increasing the ability to shift between different brain states. So what you're really doing is you're creating an environment, a behavioral effect of someone who's more cognitively flexible. And that's ultimately really the biggest point home for psychedelics I want everybody to take home. Okay, in the interest of time, I might kind of flip through this. And so just to let me just see. Oh, no, we'll have time to do it. Okay, great. All right, so mental health and psychedelics. So where are we at with this, and what does it look like? Well, in general, like I said, there's been a lot of trials. They've been out. Really good clinical data. We need more, but certainly there. Typical features of psychedelics. They tend to be fast acting, and they tend to cause acute subjective changes. I kind of just gave you a bit of an idea of why that might be the case, right? Why the fast acting, never mind the reinforced stuff down the road from the plasticity. Minimal exposures. So we're talking about 3 exposures to the medicine. That's where kind of a lot of this data is 2 or 3 exposures each. Okay. It looks like the outcomes, are either as good as our standards of care or better. So this, again, this trial here showed equivalence. The MDMA phase 3 trials are in severe treatment-resistant PTSD. The use of MDMA-assisted therapy is literally doubling placebo, and the people on placebo are on current standardized care for PTSD, or have been for years. The results are amazing. MAPS will be releasing the second phase 3 trial very shortly. Probably this fall, you're going to get the next round of results, and then that will be 2 phase 3s completed, and that's where it's going to go to FDA and probably be approved by next year. And really, from a safety point of view, very tolerable with minimal side effects. And a lot of people ask me about kind of the addictiveness of this. Well, number one, remember, it's only 3 sessions. Number two, when you take especially LSD and psilocybin, classical psychedelics, give them to rats, it actually produces anti-addictive behaviors. The others, ketamine and MDMA, it's a different story. Happy to answer questions about that. But again, the minimal drug exposures is really what's key. Okay, so what are they really doing? Like, how do you kind of look at these from a higher level framework, antidepressants versus psychedelics? Well, this is the main thing. The main kind of concept, as I kind of hopefully demonstrated with psychedelics, is by decreasing that segregation, allowing the more cognitive flexibility, you're actually increasing a person's responsiveness to go forward into the challenges that they have. So that, for example, is like I showed you with the experiential avoidance, right? That means you are more responsive to what's going on around you. You're more willing to go into it. And that's kind of what they're doing. And by mechanism of their 5-HT2A receptor, very different than the typical antidepressants, which are a little bit acting more on the serotonin 1A in general. And what they do is they decrease responsiveness. So they really kind of act more on the limbic kind of emotional processing centers to blunt emotional responses to adversity, which is, in both of these slides, as you can see, for me, they both lead to decreased depression and increased well-being. The key is they're just doing it by different actions. So what is the kind of overarching message I'm saying here is neither one is better or worse. And this is where like you got a lot of, the psychedelic culture coming forward and really putting down antidepressants and saying they have no role and how can we do this? And I mean, first off, we have to understand where we've come from. Obviously, this takes time and change, and we need evidence to support our decision making. But at the same time, looking at these two things, they both have mechanisms that are really important clinically. And ultimately, what we need to do is we need to become experts in understanding both these mechanisms such that we can use these together so that we can optimize outcomes for patients. And it might be initially, someone needs to be stabilized on an SSRI, and then once they're stabilized, you can get some therapy. Now we can go forward and try to help move them into understanding what this is all about. So it's really just coming at this as objectively as possible and trying to really understand how these work together. This is really what I wanted to mention about ketamine for depression, because I'm going to kind of end with this. As I said, the history of ketamine treating depression is totally unknown as far as I know. I mean, within, outside of certain circles, it gets a bad rap as being like horse tranquilizer. Again, I can answer questions as to why that's the case, or a street drug. And sure, I mean, these can happen. I mean, it's very good in veterinary medicine for certain reasons as an anesthetic. But the treatment behind depression came out of John Crystal's lab, he's an amazing scientist, head of neuropsychopharmacology at Yale. It came out of schizophrenia research, looking at the GABA-glutamate system. And they posited the theory that, we've been looking at this monoamine hypothesis for so long, but that accounts for like 2 to 3% of neuronal discharge, neuronal communication in the brain. What about the glutamate? Glutamate accounts for about 90% of stuff. So they actually took this from real first principles and built this up such that it became was shown as a treatment in the 2000s and kind of building from there. So amazing podcast. If you have some time to listen, about 4.5 hours of John Crystal telling the story, it's quite fascinating. Okay, to bring this home, mental health in children with neurologic disease. So this is where it kind of comes home to me. In the context of neurologic disease, I mean, we can presume, obviously, having a neurologic disease as a child is not easy. So this is a major population study, which you look at this, right? This is youth with more than one neurological disorder, and this is without neurologic disorder. So when you look at depression, overall, people with neurologic disorders, kids, make up 15% of total depressed people and 70% of in kids who have anxiety. Far outweighs tons of other neurologic disease. These are things like Tourette's, Down syndrome, epilepsy, cerebral palsy, disorder. So there's a massive disproportion of mental health challenges in kids with neurologic disease. Depression in adults has staggering stats. It's 20% lifetime prevalence. Treatment-resistant depression, 1 in 5. Relapse is bad, and it's now the second leading cause of death for adolescents. So not great. So that brings forward ketamine as a treatment for adolescents. Ketamine is safe. I mean, more or less. I mean, I'm saying that very high level, but it's a safe treatment, especially relative to other drugs that we have. This was a study that looked at IV ketamine in treatment-resistant depression, and they randomized it against midazolam. So they used midazolam as a control. And this is about 17 kids, age 13 to 17, major depressive disorder, previously tried one antidepressant, fairly severe depression. So the first group had a single dose of ketamine over 40 minutes, and the second group had a single dose of midazolam, and they did a crossover 2 weeks later, and they used depression scales to validate how they were at 24 hours post-treatment. So this is just kind of breaking down, these are the switching between the two groups, okay, and the outcome pieces as well. So, and just looking at kind of the demographics, very kind of standard, you know, here's your mean here. I've got some things lined up here, you know, at least almost 2 years of depression, failed 3 antidepressants overall, 8 suicide attempts out of 17 in a group. So quite significant depression, all right? And here you go. So this is, you know, here's your single dose, 1 dose of ketamine, and this is without therapy as well, okay? So this is just ketamine alone. And what it showed was 1 dose of ketamine has significant reduction in depression scores almost immediately. So you can see the drop here, the separation, that separation lasts up to 2 weeks. So again, this is teaching us how we're going to use these things, right? Does this answer the long-term depression? No, but can you break someone's depression? Can you do this immediately for these kids just to stabilize them such that you can get in there? And again, I'm starting to think about psychedelics as like surgery, right? It's as complex as like mind surgery. You're getting there, you're stabilizing this mind such that now we can go in with kind of other treatments and see what we can do. So this is kind of a shout out to Michael Schleigelmilk, who's really pioneered this study for CHEO, and I think he's made some partnerships at BC, and so this is extending to a multi-center trial where they're going to give ketamine for acute suicidality in the emergency department, single dose, and that's the idea I was just kind of saying. I mean, like if you can stabilize these kids in the ED. Can you get into them thereafter? So I'm gonna hold off on the functional seizure piece. I'll just kind of end with this last slide here, just to show you what is the future, right, for neurology and psychedelics, and why do I get really excited about it? It's the brain network disorders. So this is where psychiatry and neurology are totally connected, and going into psychedelics has really given me an appreciation for this in between kind of land that is elusive in the neurology and psychiatric education. Really don't have a good teaching about what's going on in this interface. And these are the interface of brain network disorders. And I think psychedelics is going to teach us a lot about this. And here are the areas that I'm very interested in. Functional seizures, psychogenic non-epileptic seizures is really the area. Given that it's a dysfunction of brain network, I'm posited that this is something that can be treated with psychedelics, and we did this in our first successful case report of a woman this is an adult who had about 2 to 3 seizures a day, and after 3 ketamine treatments, she's now a year out, and she's having about 4 to 5 seizures a month, and she's really back working again and taking care of her kids and everything. Quite amazing, fascinating case. Okay, I'm going to stop there because we're getting close. We got 10 minutes ish, I think, from my clock or so. But I'll even skip over the summary take home points. I'm going to leave this up, and thanks everybody. There's just so much to cover, and I can talk about this stuff all day.
Wow, Evan, that was an amazing presentation. Really such a great overview and really grounding it in evidence behind the psychedelics. We're hearing a lot about it in the lay media, but really grounding it in the evidence is really important. So thank you for going through that, sharing that with us. I don't know if you want to put up your summary slide there so that people can actually see that while we're going through the Q&As. Looks like you had some good things there.
Yeah, so I'll leave this up for a bit, and then I'll kind of flash over to the second one.
Sounds
talk
good.
With this much content takes a couple take-home points.
Yeah. There's a lot to think about. So thank you for leaving us some time for questions. So if you have a question or a comment, you can either put it in the chat, or you can raise your hand, or you can start talking. So I'll monitor the participant list. And I see we have Roger Zemek off the top. Go ahead, Roger.
Hi, Evan. Fantastic job. And You said how much you need to learn. I feel listening to this, I need to read a lot more as well. So as you know, one of my major interests is in concussion, and we know there's a lot of the things that you talked about and the overlap and the mental health with concussion as well. Two kind of related questions that kind of you can maybe answer it in the same way. It was really interesting how you were talking about the default mode network and the use of BDNF as a repair mechanism. We do know that both mindfulness and exercise both address both of those as well. Improve, exercise releasing BDNF and mindfulness and exercise as well as the treatments. What is the mechanism, if at all, on how these medications or opportunities for future medications, I guess is a better word, how those may also affect autonomic dysfunction, which we also think of as in the mechanism of concussion. And just curious if you think that there is a pathophysiological pathway on that, and if exercise, if someone exercises a lot, would these medications even help someone more or less if they took these?
Cool. So many great points there you pointed out, Roger. Great to see you. So I'll kind of answer the first one first. So right now we're using psychedelics in the context of assisted psychotherapy. Okay. For me, it's psychedelic assisted occupational therapy, psychedelic assisted physiotherapy, psychedelic assisted speech language pathology. So, this will happen. And I've thought about this for a long time. Again, because a lot of these pathologies are rooted in just constrained brain network dysfunction. And so when you take somebody through physiotherapy and you're moving their body and you are altering their brain networks. Now, if you can do that with a little bit of grease, a little bit of lubrication, that's what the concept is. And that's really, so you'll see that is down the road. So 100%, it complements all of these things. And I think it's really going to revolutionize our thinking to think that there is no such thing as a one medicine in isolation, maybe antibiotics, but even then, you don't take an antibiotic and lie on your couch. You go for walks, you're doing other stuff, right? So it's really bringing the holistic ideas together. Coming to post-concussion, so fascinating. So I'd love to actually talk about it with you a bit offline. So I have, this might ruffle some feathers, I don't know. I now look at persistent symptoms after concussion as functional neurological disorder. It's the same thing. And when you start looking at the brain network abnormalities in persistent concussion symptoms, and they overlap with FND, so it is a subtype of FND, and therefore it is also a brain network disorder. Now there's some evidence to support this in the neuroimaging field, but really interestingly, there's a great researcher, I think at Hopkins, and he's been treating severe post-concussion with ibogaine. Ibogaine is a real powerful psychedelic, and his results he just presented, unbelievable changes in functional neuroimaging, in addition that correlate with clinical improvement as well. So it is for me, psychedelics will be a treatment for post-concussion symptoms, but the better way to think about it from my lens is we are treating FND, and FND is the more unifying concept.
Thanks. Wow. I'll connect with you after. Love to chat more about this.
For sure. Yeah.
That's great. Thank you. We have a question from Dr. Batra. Go ahead, Dr. Batra.
Yeah, thank you very much. In the realm of imaginations, it reminds me of a movie, Limitless, played in by Bradley Cooper. And what it involved is use of medication in there after going through the hurdles, various hurdles, side effects, and everything, left a permanent effect when it increased the global connectivity to the point he was able to do all those things. Wondering if there was any medications or anything available these days which could be close in effect, which could produce some permanent brain changes so the person can carry on over.
So I guess the question there is there concern that, is it more that there's concern that by increasing this global connectedness that there can be more kind of long-term permanent changes, i.e. you don't kind of reestablish proper brain networking? I'll run with that. I think more or less that's what it was. Yeah. So that's an amazing point. And this is why I am very worried about psychedelics becoming recreationally available, because these are very powerful medications that are doing exactly what you just said, Dr. Batra. So, they are increasing your global connectedness such that you can have all these great insights, Now, if you don't have somebody to help you reestablish these in a functional way, and the hope is you're reestablishing them in a better way than you did before, yeah, you certainly run the risk of this. And we see this. This is people who are going off to these retreats, kids that go off and, you know, use big doses of LSD or take a bunch of mushrooms and mix with other drugs and come back, and we say, well, it causes psychosis, right? Because now they have permanent changes. It's like, yeah, I mean, that's what they're developing, but now you know the mechanism as to why it's happening. And now you know the dangers about psychedelics being used in kind of an unbridled fashion where you don't have the proper oversight, you don't have the proper understanding of it and everything else. So that is a very big concern. I think that's a valid point. Now, we know, though, when this is done with the right clinical context, with the right doses, with the right medical oversight, such that there are interactions are being, you know, mitigated, et cetera, so i.e. in the clinical trial scenario, which should translate to the medical arena, extremely safe, like relative to other drugs. But there's a big caveat there. It's got to be with a framework of the proper oversight.
We are at time. I was going to ask you a question briefly, and I see Katie had her hand up and then put it down. But if I can ask you this question, if you could just comment, if it's a brief response, to why these medications have such these psychedelics have such enduring effects with such small doses, like, you know, small number of doses. Is there a brief answer to that?
Sure. Yeah. And I'll just say two reasons. I think I can reinforce it with what I talked about. Number one is the acute change, right? The acute change is like that. So think about it, Mona, falling in love. When you fall in love, your brain gets so interconnected, and the person is this great thing, and everything is wonderful in the world, and you're doing things you're experientially avoiding. You're going on roller coasters, and you never would do that before. So those are the acute changes, and a lot of insight comes out of that. So that's the acute change, right? And that's why the changes are so fast. The long-term changes is the plastic changes, is the BDNF increases, the TrkB increases. So what you've done is you've kind of created an environment for the neurons to increase their functional and structural capacities. And you also double that up with the acute effects of all of these experiences you're having. So you're starting to reinforce these pathways that it's almost like they've been fertilized and are ready to grow. Now, if you do nothing about it, let's say you get all these insights and you do nothing, well, those little buds will just die away. So I kind of say inaction is the deathbed of insight. You can have all this insight, but if you do nothing about it, gone. And this is why you need psychotherapy with these things.
To be done in combination. Yeah, that's fabulous. Thank you so much, Evan. Very exciting times ahead for us. So thank you.
Yeah, definitely.
Yeah, great presentation. And I know you're off to do a merge round, so thank you for that.
Okay.
And on behalf of the audience, thank you for a fabulous presentation. We look forward to hearing more.
Yeah, for sure. And thanks so much for having me, everybody. And so nice to see familiar faces and names.
Bye, everyone.